Here we go. 1, 2, 3, go. Okay. Okay, I can see there's a few people in, so welcome. Thanks everyone for coming. We'll just wait a minute or so for everyone else to come in, and then we can get going. Okay, so welcome everyone. Good afternoon, and welcome to today's webinar titled Blenderized Tube Feeding, Balancing Science, Practice and Caregiver Perspective. My name is Amit Acharya, and I'll be your moderator for today's webinar. Before we get the webinar started, I'd like to take a moment to acknowledge the land that we are joining from today. I'm joining you from Ottawa, which is located in the unceded territory of the Algonquin Anishinaabe Nation. The lands and the waters in this region have been home to the Algonquin people for many generations, and they continue to live, work, and care for this territory today. As we gather virtually from many different places, I invite you to take a moment to reflect on the lands you are joining from and recognize the enduring presence, cultures, and contributions of First Nations, Métis, and Inuit people across the lands. A few housekeeping notes before we begin. This session has been brought to you by Cardinal Health, and we thank them for their time and expertise putting this webinar together. The session will be recorded for those who wish to revisit the material later, and it will be made available to you all. I've attached the presentation, the webinar slides to the chat box, so you can follow along if that's what you would like to do. There will be a Q&A session at the end, and please direct your questions to the Q&A box located at the bottom of your Zoom screen. Okay, a little bit about today's session. So today's session, we're going to explore blenderized tube feeding from 3 perspectives: the science behind it, the clinical and practical application, and the caregiver and lived perspective. So without further ado, let me introduce our speakers for today. So first, we got Kelsey Russell Marie. Kelsey is a registered dietitian specializing in critical illness and gut health nutrition. Since 2014, she's worked as a clinical dietitian at St. Thomas Elgin General Hospital, where she provides nutrition care for patients in the ICU and acute medicine units. In 2020, she founded Gut Health Dietitian, a growing private practice dedicated to supporting digestive health. Kelsey is passionate about advancing the role of nutrition to support gut microbiome health and is committed to improving patient outcomes across core settings. Welcome, Kelsey. Next up, we got Dr. Gina Rempel. Dr. Rempel is a neurodevelopmental pediatrician, nutrition support pediatrician, and complex care pediatrician at the University of Manitoba Faculty of Health Sciences, Max Reddy College of Medicine. She serves as a medical lead for the Pediatric Special Care Unit at the Children's Hospital of Manitoba and the Pediatric Manitoba Home Nutrition Program, a provincial program supporting children with complex needs. And finally, we've got Gareth Burkett. Gareth is the founder of Gareth is the founder of Wilbo's Blends. He launched the company to make real food blended meals more accessible for people who rely on tube feeding, inspired by his son's blended diet journey. His mission is to transform eternal nutrition by delivering convenience, choice, and improved well-being for all families worldwide. Thank you, everyone, and I'll now pass it over to Kelsey to take it away. Thanks.
Thanks for the introduction. Okay, so today my portion of the presentation is going to be focusing on some of the scientific and specifically the gut microbiome benefits, as well as the practical application of blenderized tube feeding in clinical practice. Quick disclosure, and we will move on. So today we're going to review start at the beginning. So what is blenderized tube feeding? Some of the benefits of blenderized tube feeding. We'll talk about how blenderized tube feeding supports the gut microbiota, enteral fiber intake, and how that is impacted with blenderized tube feeding. Some recipe and nutrient considerations specific to blenderized tube feeding, and then moving on to the practical application. How can we consider blenderized tube feeding in the hospital environment? And throughout, I will be referencing the ASPEN guidelines. Okay, so what is blenderized tube feeding? It really is exactly what it sounds. It's the use of whole foods blended to a consistency that's suitable to be provided through a feeding tube. So it's a approach to enteral nutrition that focuses more on food-based substrates or formulas rather than relying exclusively on our commercially manufactured formulas. And within the blenderized tube feeding arch, we have kind of two primary options. So we have our prepared or our homemade blenderized tube feeds or home blends, which is real foods blended to an appropriate consistency. So similar to as you see in the picture, kind of the idea of a smoothie, although it can be any real food ingredients blended, strained if required, and then pushed through a feeding tube. This is most commonly used in home and community settings, although we are seeing occasionally use in hospital. And then we've got our commercial blenderized tube feeding, or the idea of these real food formulas, which are manufactured formulas that include whole food ingredients. So they may have a standard formula base with the inclusion of real food ingredients, or they may be entirely real food manufactured commercial formulas. These are more commonly used in healthcare institutions because of certain benefits like having standardized nutrient profiles and the ability to be pump compatible or have longer hang times. And I will reference both throughout the presentation. So we know that over the last 10 years, especially, there's been this huge resurgence of blenderized tube feeding. And way back when, we actually started with blenderized tube feeding. So what's behind the push and what are some of the benefits? Well, we do see improved GI tolerance with blenderized tube feeding, things like reduced gagging, retching, less vomiting, less reflux, and also improved stool consistency and management of diarrhea that we so often see with our tube-fed patients. We also know that blenderized tube feeding can improve gut microbiome support. So we know that our standard commercial formulas are low diversity and often low fiber, which can perpetuate dysbiosis or an imbalance in our long-term enterally fed patients. And then we know that blenderized tube feeding aligns more with what we know about dietary diversity being such a key determinant of our gut microbiome health. Lastly, blenderized tube feeding really appeals to more cultural, psychosocial, and caregiver benefits. So it allows our patients to be included in family meal times. It allows us to honor our cultural, religious, and ethical food preferences. And it has a reduced perception of medicalized feeding. We've talked a lot within our group, for our long-term tube-fed patients, the idea of their enteral nutrition being their food rather than their feed, and reducing the medicalized nature when we're talking about it. And then we do see in addition improved caregiver satisfaction and adherence when we talk about blenderized tube feeding. Okay, so gut microbiota, this is really my area of specialty. And for anyone who's not familiar with the gut microbiota, we have this ecosystem of trillions of bacteria that live primarily in our large intestine. And these bacteria, they really are foundational in our overall health, especially when we think of our immune health and our digestion. And what we know about this gut microbiome is that it really is unique to the host. There's no such thing as a perfect gut microbiota, but we do know that having more variety of bacteria and more quantity of bacteria is really beneficial to the host. So how do we feed these bacteria? Well, they feed off dietary fiber, prebiotic fiber, but they feed off a wide variety of fibers. Different bacteria feed off different fiber. It's almost like they have taste preferences. So when we consider our enterally fed patients in our commercial enteral formulas, we know that they're highly processed and they're very low in fiber diversity. They have either single or isolated fibers, or potentially even many patients being on fiber-free formulas. We know that they also lack polyphenols and any food matrix complexity. So what happens when someone's on, a standard commercial enteral formula for a long term is that we see reduced microbial diversity, low short chain fatty acid production, and a loss of beneficial bacteria, so a loss of probiotic bacteria. And from this, we can get many side effects and negative health impacts, such as impaired gut barrier integrity, so leading to leaky gut. We can see altered immune signaling and also GI symptoms resulting. And really, I always kind of push the idea of looking at nutrition as beyond our macronutrients. So we know that adequate calories does not equal adequate microbial nourishment. We need to look at food as more than its macronutrients. Okay, when we look at fiber intake specifically in our enterally fed patients, we know it's not great. And we know it's not great in our orally fed patients as well. So everyone knows the recommendations, but adults in North America, they typically only consume 15 to 18 grams per day orally, and then hospitalized patients consume even less than this, often less than 10 grams per day. But when we look at our tube-fed patients, even patients who are on a fiber-containing polymeric formula, which often has a mixed insoluble and soluble fiber blend, they're typically only getting 10 to 15 grams per liter or 15 to 18 grams per day, which does not meet recommendations. And then that's our standard polymeric formulas. When we look at even our fiber containing semi-elemental formulas, as low as 10 or less grams per day. And then many patients that I see are on fiber-free formulas, so not getting any fiber per day. And we know that's going to have long-term impacts on their digestion and their gut microbiota health. A couple other negative impacts from a microbiota perspective of our commercial formulas is that they're highly processed and they contain a lot of additives that we know aren't great for our microbiota. So things like emulsifiers, preservatives, artificial sweeteners, and refined carbohydrates, they can all promote a dysbiosis, so an imbalance in our bacteria. They can disrupt the mucosal layer, negatively impact the gut barrier. We know that these things are generally recognized as safe in healthy adults, but we need to consider that our enterally fed patients, especially those who have no oral intake, that in the absence of any whole foods, these ingredients can become more concerning. So over time, reliance on these low fiber or fiber-free processed formulas can perpetuate a dysbiosis and impair recovery of the gut microbiota. And many of our enterally fed patients have, many health comorbidities as well. So they are not even healthy at baseline, making them more susceptible to these ingredients and, more likely to have a dysbiosis. So what are some of the fiber-related benefits of blenderized tube feeding? Well, we get that fiber diversity. Like I was saying, we need a variety of different fibers to feed a variety of different gut bacterias, and we can do this with blenderized tube feeding. We can get a wide variety of soluble and insoluble fibers from different plant foods. We know that the fermentation balance is better, so we see a slower and more stable fermentation of blenderized tube-fed fibers, so then we get less gas and bloating. We know that many of our enterally fed patients don't always tolerate fiber in their standard commercial formulas all that well, but that doesn't mean that they wouldn't tolerate fiber from a blenderized tube feed better. We also see the inclusion of polyphenols, so those powerful plant chemicals that boost short-chain fatty acid production, reduce inflammation. They have a natural viscosity that can support better gastric emptying, reducing reflux symptoms. Gina is going to get into this more. They have lower osmolarity, so we see so we see less osmotic diarrhea. And then, of course, we see that support for our gut microbiota, which is so important, better bacterial diversity and reduced amounts of pathobions. So blenderized tube feeding, the benefit really is this inclusion of whole foods. So I touched on the polyphenols. So we see that polyphenols are found in plant foods, fruits, vegetables, legume, and they act as prebiotics that support our probiotic bacteria. And we know that our standard commercial formulas are largely devoid. They don't have polyphenols. They don't have whole food ingredients in them. So when we look at the research, there's not a lot of research, and it's primarily in pediatric populations about specifically the gut microbiota and blenderized tube feeding, but more is coming. So we have our blend study, which showed increased microbial diversity and decreased proteobacteria versus standard commercial formulas. We have that category study from 2023 that showed reduced pathobiont populations and increased probiotics. And then we do see stronger impacts with our home blend formulas than even our commercial real food formulas, which makes sense. We know that data right now is limited in adults, but more is coming, like I said. And how does this work? It's these increased fermentable fibers, more resistant starches, polyphenols, and then reduction in these potentially harmful ingredients like emulsifiers and sweeteners. This is a big question I'm asked often by dietitians is how do we ensure nutrition adequacy of blenderized tube feeding, especially home blends? And I think this is, a major concern. We like control. We like to know exactly what we're providing. So the concern is this idea of variable nutrient composition and then potentially resulting in nutrient deficiency or even excess nutrient proficiency. And then potentially difficulty matching higher protein requirements, especially in conditions like critical illness or wound healing. So what does best practice look like for dietitians? Well, we're going to approach blenderized tube feeding with the same rigor as we would any of our tube-fed patients. We know that nutritional adequacy can depend on recipe analysis, the volume consistency, and ongoing RD support. But we have ways of monitoring patients. Of course, we're monitoring their weight, we're monitoring their stools, we're monitoring their labs. These things can ensure that they are receiving adequate nutrition. And we monitor and we adjust as needed, same as all of our patients. So our initial assessment is going to look very much the same. We're going to, target energy, protein, fluid, and fiber. We're going to consider micronutrient coverage, and then we're going to monitor our patients as we always do. Some micronutrients to consider in blenderized tube feeding are things like vitamin D, calcium, iron, zinc, B12, iodine, and sodium. So when you're working with families or patients on the idea of blenderized tube feeding, we're considering these micronutrients as slightly higher risk and making sure that we're covering our basis. We also know that we have our monitoring. We have the idea of strategically including foods. And then we do recommend, or the ASPEN guidelines do suggest routine multivitamin and mineral supplementation for patients who rely primarily on a home blenderized tube feeding diet. Recipe guidance. This came up quite a bit in the last talk that we gave, and Gareth actually can really speak to this. But when we're considering home blenderized tube feeding, I think again as dietitians we want to be overly prescriptive and be very concerned about the macronutrients and the micronutrients. But when we consider how we eat orally, this is not our approach at all. We know that day to day we can have significant variation in our intake, and that for most people, we have our set point, and a day of higher or lower calorie intake is not going to, result in any significant changes. So we really are promoting an idea of, avoiding these rigid one recipe fits all teaching. And when we consider from a gut microbiome perspective, if we provide a single recipe for a home blenderized tube feed diet, we are still going to be lacking that diversity of fibers that is so important, in diversity within plant foods, because we're still providing the same foods over and over. So I personally think that the idea of teaching patients and families to build their blends using a simple pattern, for instance, within each blend, we're making sure we consider a protein source, one or two fruits, a couple of vegetables, a healthy fat source, and then fluid is needed for consistency. And then you can rotate those ingredients week to week. And, the idea of matching what the family is having at meal times too. If you're providing well-balanced oral meals, there's no reason that cannot be blended into appropriate consistency and provided through the tube. And I really like that approach to blenderized tube feeding. And I think that really supports some of those, psychosocial aspects that we were talking about earlier. So, what does blenderized tube feeding look like in clinical practice? Back in 2023, ASPEN released a consensus statement. One of the major things that was brought up was hesitancy from dietitians related to concerns around bacterial contamination, the equipment, and then, of course, this risk of inadequate nutrition. What the guidelines showed is that when safe food preparation procedures are followed and then appropriate support was provided, tube feeding is typically very well tolerated and may offer gut health and other benefits. The primary barriers that we see in the hospital are things like cost, preparation, food safety, storage. We know that we have a much shorter hang time, only 2 hours is recommended for home blends. It may be requiring increased feeding volume, and then the administration of it. Oftentimes, bolus or syringe feeding is preferred. But overall, the consensus statement was very clear that ASPEN does support the use of blenderized tube feeding in hospitalized patients, and that includes not only our stable ward patients, but even hemodynamically stable patients in the ICU and our immunocompromised patients. And then they do recommend that if the home blenderized tube feeding is too difficult, that the commercial real food formulas may reduce some of those challenges and are an option as well. So, what does blenderized tube feeding look like in a hospital? As interest grows and patients actually start initiating the conversations and are requesting this, I think as dietitians, we need to start talking with our institutions about what that will look like within our hospital. So, some of the barriers that are brought up are infection prevention policies and food safety regulations. And then, of course, staff workload. It may be more labor intensive, things like storage of the formula and pump compatibility, and then what do institutionalized protocols look like? So what you need to consider is your dietitian readiness, your institution readiness, and then development of protocols and policy. What staff education is going to look like, especially with nursing staff, and then your appropriate patient selection. Or is it going to be patient driven, or are you going to be selecting patients who you feel are most appropriate? When we consider policy development, we want to consider the patient eligibility. So, do they have a mature PEG tube? Are they a stable patient? We're going to define what kind of blenderized tube feeding are you allowing? Are you allowing a commercial? Are you bringing in a commercial real food formula, or are you going to allow a prepared home blend, in particular if the patient is preparing it, and what would regulations be around that? What are the preparation standards if you happen to be considering home blends in a hospital? And then what are your administration standards, and making sure that we do follow that hang time of just the 2 hours. And then this may even look different within the hospital. You may have different standards in your ICU or acute wards versus, your chronic or rehab units. And then on discharge as well. If you're using a commercial real food formula or a commercial standard formula in a hospital, are you going to be discussing a transition to a home blend on discharge? Or are you going to be talking about discharging on a real food commercial formula, even if you don't carry that in hospital? So if you're considering starting blenderized tube feeding in hospital, there's some considerations around access and route that we need to be mindful of. So we do ideally want a PEG tube of at least 14 French and a mature stoma. So standard enteral nutrition, we know it can vary significantly surgeon to surgeon, but we can start anywhere from 4 hours post a standard PEG insertion. However, with a prepared or homemade blenderized tube feeding, it's typically recommended to delay until the tract is mature, so around 4 weeks. So typically what that would look like is the PEG is inserted, you would initiate a standard commercial formula or a commercial real food formula, even if you were considering initiation of a prepared or a homemade blenderized tube feeding, and then wait till that stoma maturity. We know that typically we prefer gastric feeding over jejunal feeding. Ideally, we want a 14 or greater French tube, although this can be worked around. I think that Gina and Gareth might be touching on this more. And then are we concerned with do we have volume tolerance concerns? Because that is one thing with blenderized tube feeding is we're often looking at more of a bolus feeding schedule, which I'm a huge proponent of. But is there a concern for volume tolerance issues there? Now, with patients who have a GJ or a J tube, it's not typically first line for blenderized tube feeding. There may be some limitations, primarily again around that volume tolerance and the hang time, as well as typically or often J tube feeding is recommended to be done by pump. Although some of the new feeding pumps are able to infuse thicker formulas, so we may be able to provide blenderized tube feeding by pump. So in those patients, perhaps a commercial real food formula may be more appropriate. Again, in the adult population, I think this is something that's very individualized and can be considered on a patient-specific basis. I do see patients that have GJ tubes that have no volume tolerance issues, and they're potentially appropriate for blenderized tube feeding. So then once we have access to route, essentially we need to consider how we're delivering our blenderized tube feeding. So are we going to be doing syringe feeding or are we going to be using pump feeding? Just being mindful of time. I think I'm almost done. So oftentimes we use bolus or syringe feeding. It aligns with the shorter hang time and it can be simple and effective. One of the big barriers, and Gina will touch on this more, is it is labor intensive. Patients may not be able to administer their own blenderized tube feeding. It does require a fair amount of strength and dexterity. Do they have family member support? So those are things to consider. If we are considering pump feeding, what are some of the indications? Potentially, if they have a J tube, if we have a poor feeding tolerance or poor volume tolerance, or if we're just lacking that dexterity and strength to provide syringe feeding. And like I said, historically, thicker formulas were not pump compatible, although with some of these new pumps, we may be able to administer, which is a great option. Typically, what we see is with prepared or homemade blenderized tube feeding, we use bolus or even gravity, although I think bolus syringe feeding is typically what's recommended, although with commercial real food formulas, we can use our pumps. And then with these new pumps, we may be able to consider bolus feeding through a pump. Okay, I think we're saving questions for the end, so we will move on to Gina.
Thanks. Can you see my slides?
I will stop sharing.
Are my slides visible?
You can share your screen now.
It says I am sharing, so
I don't see them.
They are visible, Gina. Go ahead.
Sorry.
Perfect. Okay, great. Thanks so much, Kelsey. So I'm going to continue on the blenderized nutrition support journey that Kelsey started us on, but I'm going to switch to a pediatric case because some of the things are quite different in pediatrics than in adults. And then we'll hear from Gareth on his firsthand real-life experience with doing this on a daily basis. Here's the disclaimer from Cardinal Health, and here are my personal disclosures. Perhaps the most important for me is that I really love to feed little creatures of many species. And I've learned from personal experience that using blenderized diets is really important for a host of them, even if they need technology to receive feeds like this little koala here. Because I think that the blenderized diet recognizes the importance of culturally appropriate diets that Kelsey mentioned on a number of occasions in her talk. And surely if we can blenderize eucalyptus twigs and feed them to an injured koala, my son holding this injured koala in the animal intensive care in Brisbane, Australia, surely we can figure out how to do it by gastrostomy tube in little humans too. So using a case-based format today, we're going to talk about the pros and cons of, I call it Blenderized nutrition support for children requiring nutrition support, some of the practical considerations, and the considerations for safety in the preparation of the diets at home and in the hospital. And the case we're going to use is little Rebecca, who had a very difficult start in life. She's now 11 years old, and I've known her all her life, and I've followed her with interest, and I've learned a lot from her mom and from Rebecca. When she was little, she had virtually no progress to oral feeding by the time she was 3 months of age, and she had a skin level enteral access device inserted. And despite that, we still weren't making good progress with her nutrition because her course was dominated by vomiting and constipation. She vomited every day many times. There was vomiting as well as regurgitation. And we tried everything. We investigated everything. We tried amino acid-based formulas. We slowed her feeds down. We positioned her. In fact, one of our investigations, all of which were unrevealing, was that we positioned her both right side down and right side up to see whether or not we could get more rapid emptying of the gastric contents in these positions, because sometimes that does work, but nothing seemed to work. We didn't try jejunal feeding, and I'll tell you right away why we didn't in her, because you'll see her weight here. At 23 months, she was only 7.67 kilos. And we know that in children, if they're less than 10 kilos, they have a really high incidence of morbidity when we do jejunal feedings. They have high incidence of perforation and of volvulus and of intussusception. The smaller they are, the worse it is. So we did not try jejunal feeding in her, although it was a consideration. To be frank, we're seeing less and less jejunal feeding with the incidence of, or the rising number of children who are using blended diets, because it really does improve their gastrointestinal symptoms. Now, I know I'm preaching to the choir here. You know all about growth charts, those of you involved in pediatrics, and you will recognize that Rebecca at 23 months, when we decided we really needed something different, she is very small. In children with neurodevelopmental problems, the Z-scores are really important, but don't get me started. I can spend an hour on that. But the Z-scores you'll see again when I show you her course, because they provide us with actual numbers we can compare. So we had a very little person. We knew we needed a change in direction because her growth and her nutrition were significantly impacted, which can mean impacts in development, not only in growth for children. Mom really wanted to try a home blend. She wanted to continue some oral feeding for pleasure, and in our program we always continue some oral feeding for pleasure, even if it's very limited. And I think we've learned the importance of shared decision making in any processes that involve feeding. They should be important in all our medical processes, but when it comes to eating and feeding, it's especially important because it involves so much more than just getting food into the stomach. So the pros and cons are real. They're important and they're very individual for families. One of the questions I saw in the chat before, while Kelsey was speaking, is people were asking about what about medical literacy for families? Well, we were lucky with Rebecca because her family was very interested in learning. They had high medical literacy. They were capable of providing the infrastructure that's needed, and they could afford the equipment. But those aren't always givens for families who want to do that. For families struggling with food security, they often rely on the funding they receive from the commercial products. And we can usually, I think in most of our provincial programs, certainly in our Manitoba program, we can provide the funding for the formula, but not the food. The other thing is there is a significant time commitment to procuring, preparing, storing, administering, and doing all of that safety, and that does involve a fair amount of medical literacy. Time commitment and potentially also a monetary commitment is that needed for dietitian support. And Kelsey mentioned this already. It's not that we need a daily check-in, because we do want to make this as safe and unmedical at the same time as possible, and as nutritious as possible. So, but we do need occasional monitoring. And for us, that once the children are stable, we only see them about once a year, regardless of what they're receiving. We might weigh them more often than that, but generally once a year for blood work and actual checking their fat folds and checking their growth in detail. Jejunal feeds I raise again here because the hang time is real. In children, we don't go above 5 mils per kilo per hour for the jejunal rate, and it's really hard to do that by pump. So that becomes an important consideration. In children, we also don't know where exactly that tube is in the jejunum and whether or not they're going to get appropriate absorption of the nutrients that we really want. With Rebecca's mom, we learned a lot. We learned about a store that has the name of this little creature in it, and we learned that some of the veterinary supplies that can be purchased are more important, have a greater longevity. And if families are purchasing the equipment themselves, that certainly becomes a big issue. Some difficulties with NFIT now, but certainly lots of opportunities to find equipment and supplies that allow the administration of the home blends readily. One thing that we wrote in the ASPEN guidelines that I was lucky enough to participate in generating was that if we use a straight applicator, or we call this an extension set for a skin level device, you know, this angle and this end is the same, whether it's straight or whether it's angled, but you can get fibers caught there, so that can cause plugging. Not as big a deal here in this tube, which we can change readily, but more of a deal in the tube itself, and I'll talk about that in a minute. Another thing we learned from from Rebecca was that the viscosity was really important for her in terms of her GI symptoms. She needed at least a level 2, which is on this International Dysphagia Diet Standardization Initiative, which just categorizes foods. And I'll show you in a couple more slides how we actually can measure them. We were using these standardized measurements for her already for her oral feeding. So we tried to duplicate that with the tube feeding, because some children are really viscosity dependent. And as Kelsey has mentioned, it's not the only thing that matters for them, but it can be something that we can make happen, because we know that the viscosity itself does have an impact on reflux, vomiting, and laxation. Here's some examples of the foods at the different levels, and you can see that by the time we get to level 3, that's commercial applesauce that we would measure using a spoon, and commercial pudding is a level 4, which is extremely thick. You can imagine pushing commercial pudding through a 60cc syringe. That would require considerable strength. Here is some of the it's the information, and the website is great because you do have very family friendly and healthcare provider friendly measurements that allow you to measure how thick that is. And not that we would do that every single time, but it does allow a little bit of standardization standardization of the thickness if the children are using it in different environments. So maybe grandma wants to prepare the food for a weekend and give the parents a break. She can check her blend and see that it's the right consistency to improve the tolerance and decrease the GI symptoms for the child. Kelsey already mentioned that we need some strength involved. We can, of course, administer any of these thicknesses with a syringe, but it requires considerable grip strength. If you're going to go through to this, to the moderately thick, like putting applesauce or thicker through a syringe. And this became an issue for Rebecca because her mom has a lot of small joint problems because of arthritis. And she couldn't get it, she couldn't administer it easily when it was moderately thick by syringe. Gravity, we probably can't go past slightly thick. Pump, of course, we can administer, but remember that flow time and hang time are exceedingly important. And you will hear us mentioning this over and over again. And you think that we're giving that food anyway, we're eating it. Why can't we give it by tube? Well, the more we handle it, the more safety risk is involved. And there have been incidents of very significant food poisoning for children receiving home blends. Clogging happens. I just mentioned it here. It's something that we can do something about. Prevention is probably our most important consideration, and that is with flushing and making sure that medications and food don't touch, and food, anything inside the tube should be a water sandwich. So water, food, water, and then medications, not at all mixed up together. The clogging is why we need a mature stoma, especially in children. In children, the recommendation is at least 8 weeks before we change the tube. So if we clog that tube with food in the first 8 weeks, the surgeons aren't very happy with us, because in the ASPEN safety recommendations for GT, changes in children are that we wait 8 weeks for changing the tube. Here's Rebecca's course. She never looked back. Those are her mom's words. She went from her Z-score of -3 to -2 to a very acceptable level. You may say that growth chart doesn't bear it out. And again, that's why we need the Z-scores to show it. But she really, really did well with her blenderized diet. And until she ended up in the ICU setting where she had intractable seizures. Mom really wanted to stick to the blenderized diet, but there were concerns about safety from the ICU team. The nurses were afraid of the administration time, and they also didn't really want to administer something that they weren't sure of what was in the food, and that's, of course, very understandable. And we had lack of hospital protocols. So Kelsey mentioned already that we know that blenderized nutrition support is safe in pediatric and adult patients who are ward stable, ICU stable, or ICU patients, and even the immunocompromised patients, as long as there's strict adherence to food safety measures and proper hang times. So what we did in hospital in the end was that we had no success with any of the commercial products that we tried, and Mom started administering her own food, and she administered it herself by syringe. The differences in hospital and home aren't that great when we're looking at preparation. Perhaps the biggest is, and this is again an ASPEN recommendation, that if we use gravity, that we change the bag after every use in hospital, though we may wait longer. And this is the last time I'm hammering this home, 2-hour hang time for any home prepared feeding. So Rebecca taught us about addressing some of the practical concerns, about thinking of different aspects of meal preparation and the considerations for safety in the home and in the hospital setting. And she is a real little charmer, and I have really enjoyed working with her and her mom. I'm going to pass it on to Gareth just drawing your attention to the fact that there are multiple resources at the end of my slide deck, as well as the references. And with that, I will stop sharing and invite Gareth to tell us his story.
Thank you, Gina and Kelsey. I'll just leave the disclaimer up there for a second, and then I will jump in with I'm going to cover a lot of the topics that have already been covered by Gina and Kelsey, but just bring a slightly different perspective on it. And that's the perspective that I have living and using a blended diet for, almost a decade, but also a few thousand people that we work with via Wilbo's Blends. And they tend to open up and tell us a lot more than perhaps they would with some of the clinicians that they're working with. But that's increasingly improving, I think, which is a really positive thing. So I won't cover too much into the detail of the introduction to the blended diet, but I'll give a bit more of a perspective on it. And then I'll talk a little bit about the common concerns that have already been covered, but give a different sort of take on it to an extent. And then some of the challenges, and unpack that a little bit further, and talk a bit about the evidence in the context of evidence-based practice, and then talk about some of the challenges and the problems that still exist. And I think we see those, we work in 23, 24 different countries now. And I think some of those geographic changes do change things, but the fundamentals are something that we do see crop up in most places. So the definition was already given about what blended diet is, but I think it's important to make sure that we don't think of these things as mutually exclusive. So whilst at one end of this spectrum, you've got 100% commercial formula, which has been the status quo for, since the 70s. Now, I think there's no right or wrong, and I think it's very patient specific on what works for them, and that can change depending on the setting that they're in, whether there's schools or hospice or respite involved, can change the dynamic of where it's appropriate to use certain things. But what we do see is that increasingly people start on a blended diet, typically in response to for symptom management when they've got GI intolerance typically. And then when they start on the blended diet, they can be quite nervous and tentative, but they tend to polarize towards increasing the amount of blended diet that they use. But not everybody gets all the way there. Not everybody chooses to be there. So anywhere along this spectrum works, but it's very patient specific. So why the blended diet? I think it's kind of been covered, and a lot of the research and the publications cover this, specifically around the GI intolerance that is very, very common. Gagging, reflux is often referenced, but it's often intolerance and vomiting rather than reflux. Diarrhea. So these GI intolerances typically are the reason that people start. And I always say that, if food should be first. So anybody that has a feeding tube, if we started on food, then it may be that we'd never need to move onto food to try and rectify the symptoms and manage the symptoms. So it would be a much better place if we never got there. And prevention was mentioned before, and food is a great way of prevention. And things like fundoplication and post-pyloric feeding might be able to be mitigated if we just use more food that could balance and use to mitigate the risk of GI intolerance. But what isn't talked about as much, although there's been some papers published recently that go into a bit more detail about that, are the intangible things. So when we're speaking to carers, parents, and people themselves, they just feel better. Their skin's better, their hair growth, nail growth, infections are reduced. So all of these different things that are very hard to measure in an objective way and publish a paper on, we hear anecdotally all the time that these things improve. Which is not unsurprising, given that when people have a healthier diet, typically we'd expect them to present with these similar representations of their overall health being improved. But I think the psychosocial bit, which was alluded to briefly earlier, is really, really important as well. Most people that have got a feeding tube have got a very medicalized life that nobody planned for or anticipated, particularly in pediatrics. And food is so central to every culture everywhere in the world, irrespective of, religion or anything. When there is an occasion or a celebration, food will play a significant role in that. And I think I always think about birthdays and a birthday cake. And William has never been able to eat. He's 10 years old and he's had a birthday cake every year. We put a candle in the top of an ENFit syringe and it's blown out. And it's the same with his siblings. And him being part of that, and plenty of other people have told us, when they're taken away from that situation where it's a shared meal, especially on those occasions, it has a really detrimental effect on them from a mental health point of view as well. And it's a consideration. We, as clinicians, often people think in terms of nutrition, and I try to change the language and think more in the context of food and the role that plays in all of our lives, which is far beyond just nutrition. So that said, I think some of the concerns, and I'll just address them slightly, it's already been covered. Nutritional adequacy and deficiency, it's absolutely right that it's considered and talked about. The reality is, where there's the right support and the right resources made available, we don't necessarily see this as an increased risk. And actually, the scrutiny of people that are not tube fed and what they're eating just isn't exactly the same. I think one thing that frustrates me a lot is when we talk about sole sources of nutrition, when we try to give somebody an enteral feed or a formula, then it has to be nutritionally complete. I mean, the whole term nutritionally complete makes no sense to me anyway, but to do that for every single meal also makes no sense. And I think extending that to a 24-hour period or even a week and having that food diversity is far more important. And I think we're starting to see some commentary to that and some research coming into that, particularly around the gut microbiome, which was talked about earlier by Kelsey. Food hygiene is really important. And I think if you're feeding into the stomach, less of an issue compared to post-pyloric feeding, but it's an important consideration. But again, we don't eat sterile food normally. We're not needing to eat sterile food, but it is important that we manage that. The 2-hour hang time and those considerations are really important. But at the same time, we need to think about it in a practical, sensible way of how would we apply this. And as I say, if you've got a neutropenic patient or immunocompromised patient, you need to have a very different approach than for somebody that's just eating into their having food delivered into their stomach via a gastrostomy or an NG tube. Blocked tubes, very little evidence to show that there's an increased risk of any tubes being blocked. Almost nothing that's been published on that. I think pharmaceutical products tend to be more of a culprit for that. And again, it's often given as an objection without a lot of evidence to support it. I think it's important that you can prepare it and you can, if concerned, use things like sieves to make sure that a blend is smoother and less likely to cause any problems. The type of tube size is often talked about as well, whether it should be a 12 or a 14. For buttons, it's irrelevant because the connector is the smallest part and it's the same on a 14 or a 12 or an 8. So it makes no difference. The smallest part is identical on all of them. So referencing the tube size doesn't make any sense in that context. For NG tubes and whether you use NG tubes, again, that's slightly different. And I think there's bigger considerations to be around that. Although we've got patients that are using a size 6 NG tube to deliver a blended diet effectively. One of the things that I say about from this perspective is, if you tell a patient they can't do it, there's a very good chance that they're just going to do it anyway and not tell you. So it's far better to engage with them, identify the risks, help manage those risks, rather than just close the door on it, because the risks become a lot more dangerous when it's being done behind closed doors without the appropriate support. Support and education, really critical, and I think that's really important role that healthcare professionals can deliver, identifying the right resource, signposting and being there for people. And there's more of that coming out. And there's more resources aimed for clinicians, but it's important that we also have better access to the right resources for patients and carers that want to start on a blended diet. And accessibility and cost, I think I won't talk too much about that because it does change across healthcare settings. But, funding food versus funding formulas and how they're funded in the UK, it's very different from the US and Canada. And everywhere in between. So, but there is a cost, and that cost is also in time, preparation time, storage. I know somebody that every month they blend all day on a Sunday for 8 hours solid, and that stores them up for the month. And whether that's practical for many people is debatable. So evidence-based practice, I'm not going to read this out, but broadly it's the bringing together of the best research and the practitioner expertise and judgment, and critically the service user and the values and preferences of that service user. And bringing those three things together is really important. And in the context of blended diet, when it's done well, it delivers a really dramatic and beneficial change to a lot of patients. And it's important that it is brought together. And I think in pediatrics, we see it happening more and more. In adults, I think we're still seeing that a good distance behind and not being brought together in the same way, which we would like to see change. So I'm not going to go through each of these, and you've got a copy of the slides as well. So these are some of the more recent publications on these, talking about the main topics, if you like, that come up. Safety concerns, I think, is a really important one that we talked about before. And then the clinical outcomes, I would love to see some more data on this being published. But there has been some publications on this talking about reduced length of stay, reduced inpatient admission for people on blended diet against the baseline of people on formula. And I think we'd be better if we could get larger data sets, long-term studies on this to see what the clinical outcome is and then what the health economic impact of that is. So that's one area that I'd love to see some more research being funded. Practitioner expertise and judgment. The reason that I always bring this up and want to talk about it is we kind of, in a lot of ways, block our expertise as healthcare professionals into buckets, and we apply it to somebody that's oral eating, and then we don't apply it to somebody that's being fed using an enteral feeding tube, where actually everything that we know for oral eating and all of the training and experience that we learn for oral eating typically applies to somebody that's using a feeding tube as well. And what I'd like to see is more of that crossover where we approach the patient in the same way. When they present in a certain way, why are we making a different judgment and why are we taking a different treatment approach than we would if they were oral eating, and identify whether that is actually relevant or whether actually we should be approaching it in the same way. If somebody came in and said they'd changed their diet to something and had the same thing for every single meal, and all of a sudden when they changed their diet they started vomiting, you'd say, well, maybe you need to change away from that and have a more diverse and think about what diet it is. As soon as you say that that's being delivered through an enteral feeding tube, then all of a sudden you take a different judgment, consciously or subconsciously. And I think it's important that we take a step back and readdress that before we make the conclusion and the path of treatment that we decide upon. So service user and preferences, and I'm not going to go into too much detail on this, but it's growing all the time, and even in every year, the number of people looking to choose a blended diet, and actually more clinicians are proactively recommending a blended diet from the outset now than ever there was before. This is a trend that's going to continue growing, and I think it's really important that we engage with it and find better ways of being effective in introducing it at the right time and understanding where it works. So respecting what users want is a really fundamental part in it, and it has an impact more broadly on their health and engagement that they have with their own treatment and pathways. But what I would say, and it's just to echo a bit before this, there is still a weighting towards pediatrics in this. In adults, I don't think we've seen the same adoption, but the benefits are arguably more relevant to adults, because typically in the pediatric communities there's complex neurological patients. I'm really conscious of time now that we're getting on towards, and there's a few questions. So I'll just quickly cover off at the end, just to say we are seeing change. So equipment's getting better. Some of the big companies are introducing pumps that are designed for that, and also buttons are being looked at for the next generation to see if they can work better. We need to see more coherent policies to reflect evidence-based practice and the implementation in health settings. And we need to see more products that are designed specifically for this to help clinicians in the effective use of blended diet with their patients. I think I'll stop there, and this summary you can read, but it's just to cover off what's already been said, so I won't go over it again, given time.
Thank you. Thank you. That Thanks, all three of you. That was really, really insightful. I know that we're coming kind of close to the closing time, but we do have a couple of questions that I would love to go through if that's okay. The first one is maybe this is based more towards Kelsey, but why is pump feeding not good for regular G tube feeding?
Sorry, pump feeding not good for G-tube feeding?
Yes, that's right.
Oh, I'm completely fine with pump. I just prefer a more condensed feeding schedule with true digestive breaks. So even our patients in hospital on standard polymeric formulas, I prefer to pump feed during the day or ideally work them towards more of a bolus meal schedule. We do all of this by pump. So I didn't mean there was any contraindication to pump unless you're using a home blend, in which case it may or may not be compatible.
Okay, great.
Everybody should sleep at night. So should
Everybody should sleep at night. We should not be feeding overnight.
Um, the there's a few there's a really good question here. So I know Gina, you had some resources, so that's great. What are the potential concerns with homemade blenderized tube feeding feeds?
Well, I think that portion size is really important, especially for children, and I think that the concern would be either not giving enough calories, giving too much protein. Those are all real considerations when we're talking about childhood diets, because we may not be estimating very well how much the children actually require. And many children who are technology dependent for their feeding also require a lower caloric profile, but a very resource rich one. So it just needs good monitoring and follow up of their weight and their body composition through tricep skin fold and other fat measures of their body composition.
Great. And then there's another one. I know you talked a bit about kind of the consistency and temperature. But how is frozen blenderized formula properly thawed? So that's kind of at the right temperature and consistency.
So typically you just follow good food safety practice. So typically we would say defrost in the fridge overnight, stop it going above temperature. That would be the best guidance, as it would be with anything else. I think it's important just to say, assuming that it's being fed into the stomach and not post-pyloric feeding, good health and food safety practice is universally the same and should be applied in the same way.
Shouldn't be warmed.
Yeah.
Great. We can take a couple more questions if that's okay. How about this one? How significant are the losses in real world practice with blenderized tube feeding?
I didn't quite follow the question, sorry.
Yeah, so how significant are the losses in real world practice with blenderized tube feeding? So regarding heat, blending, or prolonged storage, if there's any kind of risks. And
Oh, like micronutrient losses?
Oh.
So
It would be this. Yeah.
Heat's the main one, to be honest. And so if you've got water soluble vitamins, vitamin C, they're all compromised by heat in the same way cooking is. So I'd say that's where you have the biggest impact. Freezing has typically very little impact on it. But what it does do, which is a more important consideration in this context, is it does change the viscosity quite significantly. It changes the starches and things quite a lot. So you might blend and then it's fine for one meal. You put it in the freezer, you defrost it, and it's a completely different beast. And what we do worry about a lot is people diluting and that not calculating into that the impact of dilution. So that's something that's really important to consider as well.
Mm-hmm.
I think we'll take a final one here, actually. So the question is, why do you have to wait 4 weeks for a mature stoma?
I think,
sorry, 4 weeks. 4 weeks would be grown.
Adult.
8 weeks in children, because we don't want to have to change the tube out before that, and it does require surgery and imaging to change a tube at that stage for safety.
Great.
I'd just comment on that, just from an international point of view. We're seeing very different practice now. So in a lot of the UK now, they'll do a single phase button and they'll say do blended diet straight away, because the surgical site's more compromised by retching than it is by the chance of anything being given for blended diet. I don't think there is a universal standard practice on this. I think it's changing and evolving all the time.
It's similar to what we see surgeon to surgeon. When are we allowed to feed? Sometimes it's 48 hours, sometimes it's 4 hours.
I think that probably gives more insight into surgeons as it does than anything else.
Yeah.
Right. I think we need to help them make with those decisions.
Great, great. Well, I know that we've gone a little bit over time, but thank you again, Gareth, Gina, and Kelsey. It's been a fascinating webinar, and I know there was a number of questions that came in. So thanks again for your time. Thanks again to Cardinal Health for putting this webinar together. And we really appreciate kind of all the work and the hard work that went into putting this together. I know a number of people couldn't download the certificate of attendance and also the slide deck. There were some technical issues there, so I have left my contact details in the chat box. If you were unable to download these, please kind of get in touch with me, and I'll pass these on to you. As I mentioned, there will be a recording of this webinar, and that will be up with Cardinal Health and the Dietitians of Canada within kind of the next week or so. But thanks again for your time, and have a great rest of the day. Take care. Bye.